Okay, so I was asked to kind of give just a brief, kind of like an overview of stroke, kind of talking about ischemic stroke and hemorrhagic stroke. So that's what we did, and then we decided we would use CE. So yay. So we're going to talk a little bit of facts and stats, and then I'm going to go into ischemic stroke, kind of talking about what it is and the different types of ischemic stroke and how we treat them. And then we'll go into hemorrhagic stroke, what that is, the different types of hemorrhagic stroke, and then how we treat those. So we'll start with the facts and stats. So annually, it is estimated that about 800,000 strokes occur in the United States. Every 40 seconds, someone in the United States has a stroke, and every 4 minutes, someone dies from a stroke-related cause. 1 in 20 deaths in the United States can be attributed to stroke. Stroke kills more women annually than breast cancer, and I have a slide a little bit later that'll kind of give you a visual on that. It is the 5th leading cause of death in the United States and in Nebraska. It is the leading preventable cause of adult disability in the U.S. So about 130,000 Americans die every year from stroke. During the hour that we're going to be in this room, 90 people will have a stroke and 15 will die from stroke-related cause. Females are more likely to die from strokes than males. However, it's important to note that the stroke risk increases as we age, and women in general outlive men. So a lot more deaths happen in the older age of women. It is, so like I said, it's more prevalent in females than males. Under the age of 55, males are more likely to experience a stroke. But once you hit 55, so in the age group that they studied of 55 to 75, 1 in 5 women experiences a stroke, and 1 in 6 men have a stroke. So we kind of shift once we hit about the age of 55, and I'm getting really close to that. African Americans have a 1.5 times higher rate of mortality related to stroke than the Caucasians do. And then while the elderly have a higher rate of stroke, and if you think about stroke, most people go, well, that affects old people. That's something that happens to the elderly. It's important to know that 1/3 of the strokes that occur are happening in people younger than the age of 65. And we within Methodist and within this area have seen a pretty dramatic increase in people at the ages of 20s, 30s, and 40s having strokes. The total annual direct medical stroke-related costs, so that's your hospitalization, your emergency room visits, ambulance rides, treatment, and rehab. By the year 2030, they anticipate that the annual cost of stroke will be about $185 billion a year. So we as a healthcare team really need to take responsibility and try to educate our patients on what they can do to prevent these strokes from happening so that we can bring that cost down. 87% of strokes that occur are ischemic. That means that they're caused by a blockage, and it may be thrombotic or embolic. 13% of strokes are hemorrhagic, and if you break down that 13%, 10% are intracerebral or intraparenchymal hemorrhages, and 3% are subarachnoid hemorrhages. That's caused by a rupture of the vessel wall. So that can be related to anatomy, such as aneurysm. It can be related to sustained high blood pressure, and it can be caused by drug abuse. Transient ischemic attacks, or mini strokes, TIAs, are estimated to occur between 200,000 and 500,000 times per year. However, it is widely assumed that this is a pretty big underestimation because a lot of people will have an arm that kind of tingles, or they'll have trouble thinking of a word, and then it passes really quick because TIAs don't have to last very long. So they just think, oh, I sat on it funny, I slept on it funny, I must be getting old. And they don't go to the doctor about it, so we don't really know the true incidence of TIAs. The important thing to remember is that 1 in 4 strokes, so 25% of strokes that occur annually in the United States, are happening in somebody who's had a previous stroke or TIA. So 25% of these strokes, if we've educated, maybe we can prevent some of those strokes from occurring. So act fast versus be fast. Act fast is what you're taught in nursing school. It's what the news really kind of focuses on, is on the act fast. 80% of strokes, of people that present with a stroke, present with one of the FAST symptoms. So 80% of strokes. That means we're not capturing 20% by the acronym that we're educating people to. So about 3 years ago, we started using BFAST within the Methodist health system, and a lot of other health systems are slowly adopting BFAST. 94% of people that present with a stroke present with one of the BFAST symptoms. So we're capturing an additional 14%. Now we're not capturing a few of them that come in with that sudden confusion, those ones that are really kind of, we usually find out after the fact. But by using the BFAST, we're identifying those patients that have sudden balance issues, maybe vertigo type of issues, that type of thing. We're identifying people that their only symptom is all of a sudden now they have double vision and they didn't have it before, or they're missing part of their vision, and then face, arm, speech. And then the big thing with BFAST is we really want to focus on that T and the fact that when you have these symptoms, we want you to call 911. We do not want you to come to the hospital via private vehicle. We don't want you to go lay down and see if it passes. We don't want you to call somebody to see if they can come take you, because the workup that is done in the ED can be sped up if you come by ambulance. So if you call 911 and they recognize that you have a stroke or that you have stroke-like symptoms, they notify the emergency departments that they bring the patients to ahead of time. That patient goes straight from the ambulance into CAT scan. So we are cutting out about 10 to 15 minutes of time, and we're saving some more brain cells by taking them straight to CT because we're identifying if they're a hemorrhage or not at that point and speeding up that treatment. So signs and symptoms suggestive of a stroke. We educate our patients to understand what BFAST is, but we need to be aware of what the signs and symptoms of stroke are. So facial droop, facial numbness, motor deficit or drift, sensory deficit, ataxia, aphasia. And in aphasia, you've got three different types. You've got expressive aphasia, where they can understand what you're saying, but they can't get the words out correctly. We have receptive aphasia, they're not able to understand what you're saying, or we have global aphasia, which is both, so they can't express or understand. There's dysarthria, vertigo, diplopia, nystagmus with vertigo, visual field deficit, sudden onset of confusion, sudden onset of nausea and vomiting may be present, especially if it's a posterior stroke, so they're usually the ones that have the vertigo. And then they could have a thunderclap headache or the worst headache of their life. They may say, I heard a loud pop, and then my head started hurting. Those are usually subarachnoid hemorrhages. It's important to understand that symptoms are based on the area of the brain that's infarcted. So next year, the plan is that I will do some type of a presentation that kind of talks about if you have a stroke in this area, this is kind of the symptoms that you can expect. So I'm not going to cover that today. But common stroke symptoms, if the stroke occurs on the right side, they're more likely to have slurred speech, weakness of the left side-sided neglect, meaning that they don't recognize the left side is there, or right side gaze preference. Right hemisphere strokes are going to be impulsive. They're the patients that the call light goes off, and they're in the bathroom even before you hear the call light. They are up and going. They sometimes say very inappropriate things, and their spouse is going, oh, he would never speak like that. I don't know what's wrong with them. That's not the patient being inappropriate. That's the stroke that's causing it. They don't have the ability to kind of tamper that down. And then left hemispheric strokes, they may have the speech problems. They may have more of aphasia. They may struggle with comprehension. So you may have to explain something to them over and over and over again. You may think that they understand how to push the call button, and then they don't push the call button because they can't comprehend what you're telling them to do. These are the patients that when the call light goes off, you're like, I'm going to be in that room forever because they have to go to the bathroom because they're very slow. You kind of have to reinforce everything with them. So just be patient. That, again, is not necessarily their personality. That's damage to the brain from the stroke. They're going to have weakness or numbness on the right side, and they're going to have a left gaze preference. Brainstem stroke, nausea, vomiting, vertigo, speech problems, swallowing problems, abnormal eye movements such as nystagmus. They can have very sudden decreased consciousness, and then cross findings, meaning they could have numbness on the right side of their face and the left side of their body. So things aren't necessarily all one side with a brainstem stroke. With intracerebral hemorrhages, so the intraparenchymal hemorrhage, they can have sudden onset of nausea, vomiting, headache, one-sided weakness, and decreased consciousness. And subarachnoid hemorrhage, those are the worst headache of my life. They can be intolerant to light, and they can have neck stiffness or pain. So if we think neck stiffness and intolerant of light, we're thinking meningitis or migraine headache. We usually always do CTs on these patients so we can find out if that's what it is or if it's a subarachnoid. Risk factors of stroke. It's important to note that risk factors are cumulative. So if somebody has diabetes, high cholesterol, and hypertension, they've got a higher chance of having a stroke than somebody who just has one of those things. We have the non-modifiable risk factors, so that I've had a previous stroke or a TIA, my age as I age, my risk goes up, family history of a stroke or my ethnicity, things like that are non-modifiable. And then the other ones are those modifiable risk factors. Those are those things that we really want to educate our patients to and help make sure that they're doing what they need to do to reduce their risk of stroke. So modifiable risk factors for stroke, hypertension. With hypertension, as the blood pressure is going through really fast, your vessels have so much give in them, but with hypertension, as it keeps going, it starts running into the side, the wall of the vessel, and it causes damage to that, and then cholesterol kind of picks up, or the hypertension can go through that vessel. So AHA, the American Heart Association and Stroke Association, along with cardiovascular societies, released new guidelines for hypertension. How many people in this room know what the current normal blood pressure is? Anybody want to give me a 120 to 129 over less than 80? That is a normal blood pressure. Above that, we need to start thinking high blood pressure. So an elevated blood pressure is 120 to 120, normal blood pressure is less than 120 over 80. Elevated blood pressure is 120 to 129, and it's still less than 80 for the diastolic. High blood pressure stage 1 begins at 130 over 39, with 80 to 89 as the diastolic. And then high blood pressure stage 2 is 140 over 90, greater than 140 over 90. And you are considered hypertensive crisis if your systolic blood pressure is greater than 180 or your diastolic is greater than 120. It does not have to be both of them together. So if you're 190 over 90, you're considered hypertensive crisis, okay? And then diabetes. So patients that are diabetic are about 2 times more likely to suffer a stroke than somebody who is not diabetic. So it's really, really important that if we have a diabetic patient, that we're teaching them to make sure that they keep their hemoglobin A1C lower than 6, okay? Hyperlipidemia, there's new guidelines that just came out that have a lot of scales that the doctors can do. But for stroke, if you've had a stroke, you're already at an elevated cardiovascular risk. So if your LDL is greater than 70, you need to be on some form of a statin. If you have high cholesterol and diabetes, you need to be on a higher dose statin because the risk of damage is too high. AFib and flutter, as we know, when the heart's not beating correctly, blood can pool. Then your heart decides it's going to do a really good beat, and that clot that's pooled down there that's kind of coagulated shoots up and can go straight to the brain and cause a stroke. People with AFib, A-flutter tend to have, when they have stroke, they have larger strokes. Those clots are bigger, and they cause a lot more damage. So making sure that we're educating our patients on the importance of taking their anticoagulation and following up with their providers is really important. When somebody smokes, the chemicals in cigarettes do kind of almost the same thing that glucose and that cholesterol does, where it damages the walls of our vessels. It also causes the blood to flow slower, so you're more likely to have clotting blood kind of flowing because it's flowing slower. So if somebody is smoking and that chemical has damaged that wall, with any of these diseases, the cholesterol kind of builds into the wall of the vessel. So between the outside wall and the inside wall is where the cholesterol forms. White blood cells go, and then that creates a plaque. If that vessel on the inside starts to rupture open and some of that cholesterol comes out, our body does what it normally does when you get hurt, and it sends all these blood cells to try to clot up and stop that. That's the thrombus that can cause a stroke. That's a clot that can cause a stroke. If it breaks out the other side, we can have a hemorrhagic stroke. And then sleep apnea, this is a newer found risk factor, but it's been found that when patients have sleep apnea and they stop breathing for a while because we're not getting oxygenated blood to the brain, you're at a higher risk for stroke. And then obesity and inactivity, excessive alcohol use. For men, how many drinks can they have a night? 2. How about for women? 1. Binge drinking, bad. I'll talk a little bit about birth control pills and illegal drug use next. So illegal drug use. So this is the 5th leading cause of ischemic stroke for patients in the age group of 18 to 44. Marijuana, amphetamines, and cocaine have been the 3 that are identified to be the highest risk for stroke because of what it does to your body and to your blood and your blood vessels. Cocaine is most likely linked to stroke, And that's because of cocaine-induced vasospasm, cerebral vasculitis, enhanced platelet aggregation. It can cause hypertensive crisis and cardioembolism. So cocaine bad. Okay, so women. Birth control pills, even if it's a low dose, can increase the risk of stroke to twice that of women who are not taking birth control pills. If you smoke, that doubles. So it's pretty big if you take birth control pills and you smoke. That's a really dangerous combination. Migraine with aura. If you get auras before migraine, so you get the visual aura, the auditory aura, any of those types of things, you are 10 times more likely to suffer a stroke than somebody who does not have migraines. Hormone replacement therapy, that increases your risk of stroke only slightly. So after somebody has a hysterectomy or if they're going through menopause and they get put on estrogen, it raises your risk, not a huge amount, but it does raise your risk. And then people that have clotting disorders, women that have clotting disorders. And one of the studies I looked at talked about women who had suffered more than one miscarriage. Those women are more likely to have an embolic type of stroke. But that diagram over on the other side, if you can tell, there's twice as many females that have died related to stroke annually than breast cancer. My husband was trying to tell a gal that he works with who isn't a very healthy person, and she likes to smoke a lot, and he was trying to tell her, you know, you're at a higher risk for having a stroke. Women have a lot of strokes. And she goes, breast cancer kills more people than women. And he goes, not according to my law. He listens. Doesn't happen very often. Okay, so to the meat and the potatoes, we're going to talk about ischemic stroke next. So an ischemic stroke is a blockage in the blood vessel that prevents oxygenated blood from traveling to the brain. If it happens in the heart, that's a heart attack, it's ischemia. So it's that blockage that's preventing oxygenated blood. The initial region that is blocked from oxygenated blood is what we call the core of the stroke. That tissue is presumed that it dies within minutes of losing oxygenated blood flow. The penumbra is the surrounding tissue, and if that has a decreased or marginal perfusion, the penumbra tissue may be salvaged. They believe it remains viable for several hours. So there's some things that we can do to try to salvage that area. So my favorite picture in relation to stroke, if you can see this little black area right here, that's the core stroke that happened to this patient. The area that's pink all around it, right there, that's the penumbra at the time that the stroke happened. So we've lost blood flow to that core section, and we've got decreased blood flow going to that small area around it. If we do nothing, within hours, if you can tell, now we have a much larger area of black. So some of that penumbra has died, but the penumbra area has kind of extended out. So now we've got more risk for death, tissue death there. And if we do nothing within days, when the stroke is finally completed, notice how much of that area is now black. We're not getting that tissue back. It is gone. So that's the reason that it's so important that we get people into the hospital right away when they have these symptoms, because maybe we can do something to treat them. The average duration of a stroke is about 10 hours. So you have your stroke, you start to have symptoms. Your symptoms can get much worse, or they can stop. So a stroke lasts usually from 6 to 18 hours, but the average duration is 10. The average number of neurons in the human forebrain is 22 billion. So if a patient is having a large vessel stroke, so this is an MPA stroke, they lose 120 million neurons, 830 billion synapses, and 447 miles of myelinated fibers each hour that this happens. So if you think their stroke lasts 10 hours, that's a whole lot of nerve cells that we're losing in our brain. A lot of communication not happening. And each hour, the ischemic brain ages 3.6 years without treatment. So I just had a birthday and just turned 50. I'm not very happy that I'm 50. I don't want to be 53.6 in an hour. So we really need to do what we can to get patients into the hospital faster. In each minute, 1.9 million neurons, 14 billion synapses, and 7.5 miles of myelinated fibers are lost and destroyed. So when I talk about calling 911, they let us know ahead of time. We take them straight to CAT scan. We're saving 15 minutes of brain cells. Whereas if they come in, they have to get checked in, they have to get seen by a nurse and a doctor, and then maybe we can get them to a CT scan. Much faster if they come by ambulance. Okay, so ischemic stroke classifications. We have the embolic stroke, we have a large vessel thrombotic stroke, and we have a small vessel thrombotic stroke, which is known as a lacunar stroke. How many people have heard the term lacunar stroke and went, I don't know what that is? I was in this position for probably 5 or 6 months, and I kept seeing lacunar stroke, and I thought, I should really know what that is. I don't want to ask Dr. Franco what that is. So I reached out to my friend Google, and I started doing some research. So I'm going to kind of help you not have to do that, so I'm going to tell you about that. I'm going to show you a little video here. It kind of shows a little bit of an example of what stroke is. I don't think this is the one with sound. So embolic ischemic stroke, this is when you have a blood clot or an embolus that forms somewhere else in the body and travels to the brain. This often occurs after heart surgery or if somebody's got heart disease, AFib, aflutter, that type of thing. So the blood clot forms somewhere else. So an AFib is going to form in the heart's going to beat normal, and that embolus is going to go to the brain. So that's the embolic stroke. A thrombotic stroke is a blood clot that forms in the artery of the brain that supplies blood to the brain. This is usually seen in older persons, and part of that is because that little cholesterol plaque area that's forming in your artery can take years to kind of get to the point where it really blocks things. So that's why you see it a lot more often in older people, because they've had that for a long time and it just keeps building. Large vessel thrombosis is the most common type of thrombotic stroke, and the blood flow is generally blocked in one of the larger arteries such as the MCA or the ACA. And this video is just a little portion of that other one, so I'm not going to say that one. Okay. Lacunar stroke, this is a stroke that occurs in the small blood vessels, so it's happening in these small vessels that are feeding kind of the inner part of your brain. Approximately 20% of strokes are classified as being lacunar. I think I looked at some of our data, and we see probably 40% of our strokes are considered lacunar in strokes. But this video here, I think, is a pretty good one. I like the doctor's accent. And two, I think that he explains it really well. Okay, so treatment options for ischemic stroke. If the patient gets to the emergency department within 4.5 hours of the last time known well, so that's not necessarily the same as symptom onset. So you could be having a conversation with somebody at 9 o'clock in the morning and say, you know, I woke up this morning and my arm was numb. Well, what time was that? 6 o'clock. Is that symptom onset or is that last time known well? 6 o'clock would be symptom, when they recognize the symptom. Last time known well would be the last time somebody saw them or they knew that they were normal. So most likely that's the night before. So that patient is outside the window for IV TPA or thrombolytic therapy. And there are certain eligibility requirements that they have to meet to get this. Some patients are willing to take TPA, and others are afraid of it because it's a pretty major blood thinner that we're giving you, and we give it you systemically. So if you could bleed anywhere in your body with it, but truly our doctors are very, very good at identifying those patients that are the right candidates, and we don't have a lot of transformation from this. I think in the last 3 years we've had one. So we're really good at making sure that we're not giving it inappropriately. But I'm going to show you this video. Okay. And then the other option that we have to treat a stroke, to reverse the stroke, is mechanical thrombectomy. We have 24 hours from last time known well to do a mechanical thrombectomy. Not every patient is a candidate for this. This is only those patients that have a large vessel occlusion that can be identified in the lower distal part of the MCA or the ACA. We can't do posterior circulation with thrombectomy. They just can't feed the catheter from the groin up to that area. And about 20% of strokes, maybe closer to 17, but about 17 to 20% of strokes are actually large vessel strokes. So the majority of people that have a stroke are having that lacunar infarct or a smaller area or an area that they can. We do not have a provider that does the thrombectomies here. If we recognize a patient with a large vessel, we quickly get them transferred to Nebraska Medicine, and they have 3 interventional neurosurgeons that do the procedure. It would be nice if we would have one, but we just don't. So one of the things that Omaha has done is OFD will actually do a scale on a patient. They do a kind of a test when they pick up a patient. If the scale is high enough, they automatically take them to Nebraska Med so that they bypass hospitals that can't do that.
I have a question about that. Patient that had a stroke, well, actually having a heart attack, but what became they thought he was having a stroke, and they told the wife, you have 1 minute to decide where to go. Having a stroke, Bergen, Manual. They didn't offer methods, and they wanted to come to methods because they were methods.
That's one that we're going to have to kind of follow up with them because Bergen doesn't have anybody that knows that. Emmanuel has one physician that does the thrombectomy, and then the next one has to.
So that's where they were going with that, because they thought it was thrombectomy.
Yeah. So yeah, that's a little, but I probably need to get some more information so we can kind of follow up with that on that one. So what if the patient gets here too late, or they don't qualify for any of those interventions? What do we do? The one thing that we can do is we can allow their blood pressure to go high. So we call it permissive hypertension, and they can go 220 over 120 for about 48 hours. Sometimes the doctor will let them go 72, but it's generally about 48 hours. And the goal is that by forcing higher blood pressure, by allowing higher blood pressure, we're getting some perfusion to that area that's at risk of dying. So hopefully we can salvage some of that. But that's about really the only thing that we can do. So then at that point, we start trying to figure out, why did they have the stroke? What diagnostic studies do we do? So we're going to do cardiac studies. We're going to find out if it's an embolic stroke. We're going to do lipids. We're going to do carotid studies to determine, is this something that's caused by plaque buildup. Then once we identify what the cause is, we're going to treat that cause. Sometimes it's the carotid endarterectomies that they're going to do. Sometimes it's we start them on an anticoagulant because they didn't know that they were in AFib, and they are. We start working with therapies because we need to try to do everything that we can to get them back to as close to their baseline as we possibly can. And we as nurses can do a lot, but if it wasn't for therapies, half of these people would be bedridden because they're the ones that are getting them up, teaching them to walk, teaching them to speak, teaching them to swallow again. So it's truly a team event to try to get them back to where they were. And then we need to work on prevention and management of complications. So we know that these patients that have strokes, the number one complication of a stroke is aspiration pneumonia. So how do we prevent that? We do a bedside swallow screen before we let them have anything by mouth. If they fail that, we keep them NPO until speech therapy can see them and assess them a little bit more thoroughly and make their recommendations. Sometimes it's a peg tube, sometimes they are fine to eat. But we never give them anything by mouth until that swallow screen is done if we are suspecting a stroke. Because that aspiration pneumonia is one of the biggest complications and the biggest causes of death outside of the stroke itself. We make sure that they have STDs or pharmacological interventions to help prevent more clots from traveling. So we don't want them to have a DVT, so we're going to make sure that we're doing those things. Oops, I'm going to fall. So transient ischemic attack. So this is that mini stroke, that TIA. So TIA is officially defined as a transient episode of neurological dysfunction caused by focal brain, spinal cord, or retinal ischemia without acute infarction. So there's no evidence on an MRI that they actually had an event that happened. I like to look at it this way. Transient is a brief, temporary, or fleeting. Ischemic, we've lacked blood supply. There's no blood getting there. And an attack is an episode or an event. So a transient ischemic attack is something that's fleeting, it's brief, they have no blood flow to an area, and then it goes away. Duration of symptoms is about 24 hours, less than 24 hours. They usually last less than 5 minutes, and the average duration is 1 minute. So again, 1 minute of an arm numbness, we don't necessarily think that this is something wrong. We don't go to the doctor. When they did surveys of people who have had a stroke, approximately 40% of people who have experienced an ischemic stroke report that they've had some form of TIA-type symptoms prior to their stroke. And again, I kind of talked earlier, 200 to 500,000 people, a low estimate, are estimated to have a TIA. And the video I'm going to show now is actually a gentleman, another one with a great accent, who had a TIA and then went on to have a stroke. So it's kind of his talk about why it's so important to kind of tell people that they're at risk for stroke after these events. So this is why we have one order set that we use for stroke and TIA. We need to do the same diagnostic studies, even if the symptoms have resolved, because we need to try to find out why they had it so we can prevent it. A TIA can be caused by a blood clot that comes up and then just breaks apart, somehow gets moved out of the way so it's no longer blocking it. It can be caused by a piece of plaque that breaks off and then just kind of floats away or gets dissolved, moves away. So a TIA is generally caused by the same thing that ultimately causes the stroke. Does that answer your question on TIA? Okay, so hemorrhagic stroke. Hemorrhagic stroke is quite basically, it's a brain bleed. It's bleeding within the brain. So a hemorrhagic stroke is caused by either a brain aneurysm that bursts or ruptures or a weakened blood vessel that leaks. Blood spills into or around the brain. This creates swelling and increases pressure on the brain, which causes cells and tissues which damages the cells and tissues in the brain and can ultimately cause them to die. There are two types of hemorrhagic stroke. There's the intracerebral or intraparenchymal stroke, and then there's the subarachnoid. About 13% of strokes are hemorrhagic. So with an intraparenchymal, I can never say that word quite right. Bleeding is within the actual brain tissue itself, and it's often referred to as the intracerebral hemorrhage. So actually an intracerebral hemorrhage is kind of both of them, but it tends to be that doctors say this is an ICH, and it's actually like the IPH. Subarachnoid is the bleeding that happens between the brain and the skull. High morbidity and mortality rates within hemorrhagic strokes. 30-day mortality is reported to range anywhere from 30 to 52%, depending upon the study. And only 1/5 to 1/3 of patients that have a hemorrhagic stroke are able to be classified as independent at 6 months. So after 6 months, most of these patients still need assistance doing activities of daily living. It accounts for 30% of strokes that occur annually. So again, 13% of strokes are hemorrhagic, but it's 30% of the death. Intraparenchymal hemorrhage, like I said, is the bleeding that occurs into the brain, which is the functional portion of your brain. The most common cause is leakage from a small intracerebral artery that has been damaged by chronic hypertension. So after a while, you just start losing the elasticity of those vessels, and you've got high blood pressure, and it just has to go somewhere, so it just makes room. So you can have this caused by other bleeding issues, other bleeding diathesis. Ischemic, I can never say that word either, anticoagulation. So that's those patients that are on Coumadin, any of those kind of things that's going to cause their blood to flow a little bit faster and easier. Cerebral amyloidosis and cocaine abuse. They can also have this type of a bleed resulting from a fall or an accident or trauma and metastatic disease. While those aren't classified as strokes because they're traumatic or it's related to the cancer, we still do the same thing for them. We're still going to try to keep their blood pressure where we need to. We're still going to monitor them as closely as we would if it was a stroke. So in the IPH, small, deep penetrating arteries that are susceptible to loss of elasticity with hypertension rupture easily. Once that bleeding happens, a clot forms. That clot causes a mass effect. So there's like a rock right in the middle of it. And that irritates the surrounding tissue, and it causes swelling or edema within the area of the bleed. Plasma proteins diffuse out into the area surrounding the hemorrhage, which worsens the edema. As that blood product starts to degrade, the products within the blood are toxic to the brain and the surrounding vessels, so further damage happens. Ischemia and decreased perfusion occur around the clot, and if the bleed is caused by hypertension, somewhere around 40% of them will rebleed, or it'll extend, it'll continue to bleed. So the clot breaks up, but the bleeding has to stop, so it starts to bleed again, which is one of the reasons why we keep them in the ICU for 24 hours. Hopefully the bleeding is stopped, but if it opens again, we can hopefully recognize the symptoms. Common complications of the intraparenchymal hemorrhage is rapid neurological decline, in part due to the early hematoma growth. They can have injury from that hematoma, and then the bleeding can actually obstruct the ventricle, so they can get obstructive hydrocephalus. Those are the patients that we end up putting a drain to try to get some relief to them. The mass of blood in the brain, so that clot, can grow to be the size of a golf ball, a plum, or larger. So think about your head, how big it is. There's not a lot of room for your brain to move around, and now all of a sudden you have a golf ball sitting in the middle of it of blood. So there's just so much damage. It's just such a tight space. They can have continuing bleeding. This can break down the blood-brain barrier, and the mass can put pressure on cerebral tissues and nerves, which lead to the death of that tissue. So treatment of these type of hemorrhages, blood pressure control. We want the systolic to remain less than 140. It's still above what we want as a normal blood pressure, but we want to bring that blood pressure down to at least less than 140 so that we can try to slow the flow of blood. With ischemic stroke, we want blood pressure high to get blood to it. With hemorrhagic, we want to stop the blood going to that area. We can give blood products to kind of help that clotting process and kind of get the bleeding to stop. If they're taking Coumadin, we want to give them vitamin K or Kcentra. Kcentra is a reversal agent for Coumadin. It's given over about 25 minutes, and it has a pretty good turnaround time to stop that bleeding. There is a new reversal agent for the other newer agents, newer anticoagulation agents such as Eliquis and that type of thing. We don't have any in-house yet. It's still on back order. It's a newer company, a newer pharmaceutical company that made this, and they're very small, and they just can't keep up with the demand. So currently, the current demand is going to academic centers and large hospitals because those are the patients that usually get transferred to them. The goal is that at some point somebody else is going to buy them and everybody will have it. But because that's such a new drug, the cost of treatment for that is anywhere from $25,000 to $50,000 a dose. So.
Yeah, real quick. Can I piggyback with a slide or two? When you were talking about trauma and hemorrhagic strokes, you said that they're not considered a stroke, but we treat them the same here. Can you kind of explain a little bit? I mean, they're not classified as a stroke.
They're not classified as stroke as far as they're not considered an acute event that happens internally. So there's something externally that's happening. So it's either the cause of the fall that created it, or it's a tumor growth that's bleeding within the tumor. So they're not classified as a stroke as far as like a coating and things like that, but the damage is the same. So if you fall and you get a bleed in the brain, you're going to have the same damage as if you all of a sudden had a hypertensive stroke. So the damage is the same. So that's why we treat them the same. But as far as classification of stroke, those don't actually fall under the stroke categories.
We have classified those trauma and traumatic brain injury.
Correct. But the damage is the same.
As far as like I work on neurology, where we've had patients fall and then have liver hemorrhages where they have metastatic bleeding. But if they're presenting like stroke like symptoms, we would still call it stroke.
Correct. Correct. Right. And the reason that you do that is because we can get more rapid imaging and find out what's going on. And again, you're going to do the same thing for them. We're still going to keep their blood pressure lower. Okay. So subarachnoid hemorrhage. With a subarachnoid hemorrhage, the bleeding occurs between the brain and the skull. Now, 80% of them are related to a ruptured aneurysm. 10% or 20% are related to other causes. If you look at this image, this patient probably had an aneurysm right in about here that ruptured, and so it filled that space. So then the brain starts to shift up and move. Because again, there's only so much space. The brain is soft, so the brain gives. There's no sound in this one. So the blood is going into there, into that aneurysm, and it ruptures. And if you see in that video how fast it came out, that's why subarachnoids, they have this, many of them say that they have a loud bang in their brain. That's that aneurysm rupturing. So if you think about a balloon that you've blown up and you blow it really big, and then it pops, that big sound, that's what's happening in the brain. That's why they say thunderclap headache. They hear that noise. Subarachnoid hemorrhages have a 33 to 45% mortality rate. If the subarachnoid is caused by an aneurysm rupture, they have worse outcomes. Part of that is because that's usually in an area where there's higher blood pressure kind of shooting through that area, so they have worse outcomes. Causes uncontrolled hypertension, smoking, family history of aneurysms, alcohol abuse, genetic syndromes such as polycystic kidney disease. No clue why that one was picked out, but they found a link between people having polycystic kidney disease and having aneurysms. And then cocaine use. Notice cocaine's in all of them. So a subarachnoid hemorrhage may result in elevated intracranial pressure and impaired cerebral autoregulation. 10% of patients that have a subarachnoid hemorrhage will die before they ever make it to the hospital because those bleed and they bleed fast. There's a high rate of rebleeding if we don't do anything. 10 to 20% of them will rebleed within 14 days. 50% will rebleed within 6 weeks. So we see a lot of subarachnoids that we think they're fine and we send them home and then, by gosh, they're back. They tend to rebleed. So there are some things that we can do to kind of treat aneurysms. There's coils, catheters. Balloons are not used very often anymore. So I'm not going to show a video of that, but basically a balloon is blown up by the aneurysm to hopefully stop the blood from going in there. and then they can place stents. So clipping of an aneurysm, they do an outside, so they have to do a craniotomy, and then they go into the area where the aneurysm is, and they place a clip at the base of the aneurysm to prevent blood from flowing into it. That aneurysm will basically die off, and the clip just stays in place. There's a very high rate of success with clipping. Usually patients that have clipping don't have to go back and have scans because they know that they're going to stay in place. Only about 1% of them will actually ever have a bleeding from an aneurysm that's been clipped. A couple more videos. The next choice is coiling of an aneurysm. This is, again, they go in through the femoral artery and they pass it up to the area where the aneurysm is, and they release platinum coils into the aneurysm, and it fills it up, hoping that the blood is unable to enter that sac. Sometimes if the base of the aneurysm is too wide, they have to place a stent to kind of hold that coil up in place. This is less reliable than clipping. They think about 20% the clips or the coilings fail, and they have to go in and do a recoil.
When did it decide to be coiling or clipping?
It's up to the surgeon's preference. If the base of the aneurysm is wide, like it was on that one, the coil can come out. So that's when they put the stent in. They look at the size of it and determine if it's one that's going to be able to hold the coil or not. We do not do those here at Methodist either. That's another thing that we would transfer somebody to Nebraska Med for.
The brain aneurysm is a bubble of blister that forms.
It's a blood or a blister. Okay. So the other thing that they can do for somebody with a hemorrhagic stroke is sometimes they have to do a flap. So they have to take a piece of the skull out to allow the brain to swell, to evacuate some of that blood. They can do that for both types of strokes, depending upon how much brain swelling they have. But generally, it's clipping or coiling.
So more invasive though.
Clipping is more invasive. So there's higher chance of infection with that and complications. So they really have to kind of take a look at the patient. And a lot of it depends on their age as well. Dr. Long always does clipping. Dr. Thorell does coiling. So a lot of it depends on what their comfort is.
So if someone comes in with a stroke that went away from TIA, but they can't really find any cause of what would they call it TIA?
Yes. Yes. There is about 20% of strokes they can't determine what the cause is. They're called cryptogenic. Usually if it's a TIA or even if we think it's a cryptogenic, those are usually the patients that will go home on a heart monitor so we can continue to look. Because sometimes somebody can have AFib for a period and then it stops and then it comes back. So we'll put them on a monitor for longer so we can kind of see if we can capture it. And we send them home on medication for cholesterol. We send them home, you know, on antiplatelets, all of those type of things. I know which patch you're talking about. It's just a patch. Yeah. We'll put in a smaller device, and for some reason can't think of the name of it. The loop recorder. Thank you. And the loop recorder will monitor your heart for 3 years, so they can kind of see it further out. And the studies on that have really shown that there's an increased number of people that have that AFib that kind of pops here and there. Okay, any other questions? Then you guys are good to go.